buon pomeriggio, io sono Bernardo Dell'Osso, Università di Milano, ASST Sacco Fate Bene Fratelli. Benvenuti, bentrovati a questa sessione inaugurale ed internazionale della SINPF. Vi devo dire che quando con i presidenti Claudio Mencacci e Matteo Balestrieri abbiamo ragionato su chi potesse essere lo speaker per questa sessione inaugurale, non ci abbiamo messo neanche un minuto a trovare consenso nella persona del professor Edoard Vieta. Quindi io ringrazio, lo vedo collegato, quindi solo qualche parola per introdurre il professor Vieta. Hi Edoard, can you hear us?
Yes, I can hear you very well. Can you hear me too?
Okay. Thanks for accepting this invitation to present at the annual Congress of the Italian Society of Neuropsychopharmacology. I'm sure that the entire audience here is familiar with the research and studies of Professor Vieta and his group in the field of affective disorders, in particular bipolar disorders. So Professor Vieta, just to mention a few of his numerous appointments and affiliation, he is Professor of Psychiatry at the University of Barcelona. He is the Director of the Psychiatric Unit at the Clinic Hospital in Barcelona. He's in the Executive Board of the European College of Neuropsychopharmacology, and he's the Editor-in-Chief of European Neuropsychopharmacology. So Professor Vieta today will speak about new advances and future direction in the diagnosis and management of bipolar disorders. So please, Edoard, and thanks for being here with us today.
Grazie Bernardo, grazie professor Dell'Osso. Voglio ringraziare il professor Dell'Osso e gli organizzatori e la Società Italiana di Neuropsicofarmacologia per il loro gentile invito. Parlerò in inglese perché capisco l'italiano, ma non lo parlo bene. So unfortunately, I'm going to switch to English now, and I will share my screen so you can actually see my slides. So hopefully you can see my slides now. And unless you say no, I will start talking. The title of my talk is New Advances and Future Directions in the Diagnosis and Management of Bipolar Disorder. I want to show my potential conflicts of interest because I do research, clinical trials in search for better treatments for patients. I do a lot of educational talks, and I also do consultancy with companies to advise on clinical trial design and research on new compounds. One of the first things I'd like to discuss is whether bipolar disorder is a mitochondrial disease. And I start with this because this talk will be mostly about recent advances. So I'm not trying to cover everything about bipolar disorder and to make a review on the psychopathology, clinical features, and things that we already know. So I'm giving a talk that assumes that most of you, quite sure, are already very familiar with the condition. And what I'd like to give you is an update, a top-level update on the novelties in research and in understanding this condition. And one of the important topics is the issue of bipolar disorder as a potentially mitochondrial disease. So this is a study that is done by our group. There are several groups working in this approach. One of the most important ones is in Toronto. It's Anna Andreazza's group. And along with them, we are working now on this hypothesis. And we have recently published a paper based on a longitudinal study with 20 patients, and we analyzed the respiratory capacity of cells during acute and remission states in terms of bipolar disorder symptoms. And we found that there were bioenergetic and mitochondrial abnormalities during acute episodes that actually remitted when the symptoms abated. So there are changes in mitochondrial function, especially during the acute episodes of the disease, and this is an avenue for search of new treatments. Another important finding that has been replicated a few times, but not always replicated, is the influence of cannabis in developing this condition. This paper, published in JAMA Psychiatry very recently, last year, actually analyzed the data from the Danish National Registry. The Danish National Registry, as well as the Swedish, the Finnish, and now we also have a national registry in Catalonia in Spain, and there is another one, important one in Taiwan, have been very helpful to analyze the whole population and big samples of patients with several conditions, including bipolar disorder. In this study, with over 6.6 million people, which are the people who live in Denmark, what was analyzed was the relationship between reported cannabis use in the healthcare database and bipolar disorder. And there is a clear relationship between the two. Of course, the study doesn't clarify which is the directionality of the causality. So, but probably it's a double way. So we know by other papers as well that cannabis use can precipitate or trigger bipolar disorder, and we know that having bipolar disorder may increase the risk of consuming cannabis. So clearly, this is a sort of comorbidity that is important to address because from other studies, we know that stopping cannabis consumption can improve the outcome and course of bipolar disorder. In fact, we replicated this finding in this very recent paper published in the British Medical Journal with a lot of authors from several countries, including an Italian author, Marco Solmi, who was the lead author of this important paper, that was the largest study ever done on the effects of cannabis, looking not only in the negative effects, but also the positive effects. Clearly, this important study shows that cannabis has many more shortcomings and problems than benefits. There are some benefits in some subsets of population. For example, people with multiple sclerosis may benefit from the spasticity symptoms with derivatives from cannabis. But this is particularly true for CBD. So this is the cannabidiol, which is the compound of cannabis that does not carry risk of addiction. The problem is with tetrahydrocannabidiol, which is the addictive part. And then there are also a few benefits in terms of pain relief and antiemetic effects, for example, in people with cancer and who are taking chemotherapy. But for the majority of population, cannabis is not only a substance that may cause addiction, but also in this largest study ever, umbrella review, it is shown that the risk of psychosis and inducing bipolar disorder, first episode bipolar, is a reality. More new learnings from recent papers. This is a paper that is now submitted and is one of probably the first biomarker that can be used in the diagnosis of bipolar depression. This actually comes from an European project that was funded by IT Health, and the product is already in the market in France and Italy, and it's called EDIT-B. And this is a product that is a kit of several epigenetic markers that are able to provide an accuracy of around 83% for the diagnosis of bipolar depression as compared to unipolar. I don't need to tell you the importance of separating bipolar depression from unipolar depression, but still many patients remain misdiagnosed as depressives while they are actually bipolar 2 or bipolar 1. The reason for that is especially hypomania that is difficult to recognize retrospectively, but it is important because the treatment of bipolar depression is largely different from the treatment of unipolar depression. And if you prescribe antidepressants as monotherapy without adjunctive mood stabilizers or some antipsychotic, you can actually induce a manic episode in a patient with depression in whom the background is actually bipolar depression. So this is a novelty in the framework of precision psychiatry. And this is an area that my group and I have been working on over the past years. And we are trying to promote, because precision psychiatry is not only the future of our profession, it's also the present. Another aspect that I think is relevant for anyone working in bipolar disorder is to understand the concept of neuroprogression. And there's been a debate in the literature, and there are groups that tend to deny neuroprogression. They say that all of the harm is already there. Like in schizophrenia, they say most of the harm is there because it's a neurodevelopmental disease. And honestly, I don't actually agree on that. I think this is one of the main differences between schizophrenia and bipolar disorder. In schizophrenia, most of the cognitive problems are there even before the first episode. It's a neurodevelopmental disease, and it's a condition that even when people haven't developed the first episode, they have already some cognitive problems that most commonly go undetected because there's been no reason to go to the doctor. But in bipolar, many of these patients have a very high cognitive reserve, a cognitive profile before illness onset. And there are plenty of studies that show that before illness onset, the people who developed bipolar disorder had a high level and a high intellectual level. So this study is relevant because in this study that we co-authored along with a big group of international investigators in the Enigma consortium, we found out that the number of manic episodes is correlated longitudinally, and this is very important because it's a prospective follow-up study with cortical thinning. So there is a loss of gray matter that is correlated with the number of manic episodes. It means that most of the cognitive problems, especially in bipolar 1 disorder, have to do with the repetitive manic episodes and the functional consequences of those episodes. In fact, many of the patients with bipolar disorder show some cognitive problems that are not particularly related to age, but particularly related to illness course. And one area of research for our group is we have a special interest also in the elderly bipolar. So in this International Society for Bipolar Disorders Task Force consensus that we led, we actually found out that the old age patients actually have a less burden of mania, but still some burden of depression, and that the best way to measure their functioning is to use specific scales. One example is the FAST-O, which is the functioning assessment short test that is adapted to older patients. So this is the FAST is a scale that is now used in many clinical trials and many research projects. That it's a scale that we developed for bipolar patients, but it's used also in depression, schizophrenia, and other conditions. And now there is a particular version for older age bipolars that is recommended by the ISBD. Another study that we also took part of, and it's again a large consortium study because it comes from the Conligen Consortium, which is a group of investigators interested in the genetics of lithium response, trying to find genetic markers that may predict good response to lithium. This is a publication in Molecular Psychiatry last year that shows how we found out some genes that were related to lithium response. Initially, we reported that and published in Lancet. And then what we've done this year was to check the utility of PRS. You're probably familiar with the concept of PRS, polygenic risk score. It's now being used in this framework of precision psychiatry to identify people who have greater proneness or likelihood of developing a given condition. So everyone has a PRS for several conditions. And in particular, if you have a high PRS for bipolar, you are more likely to develop bipolar disorder. But of course, the PRS is not perfect and the genetics don't explain everything. But in this study, with a big number of patients, over 3,000 patients from several places in the world, we found out and we confirmed that the PRS, the polygenic risk score, actually for bipolar disorder was a predictor of lithium response. Also, in that study, we confirmed the involvement of glutamatergic and cholinergic mechanisms in these genes. So it probably means that some genes related to malfunction of glutamatergic and cholinergic mechanisms are involved in the mechanism of action of lithium and in the prediction of response to this compound. In fact, one of the problems I foresee in the present and in the future is the declining use of lithium. We have analyzed along again with a large group of international investigators what are the prescription patterns worldwide. We know that in the US, the lithium use has declined over years for several reasons. One of the reasons is that the marketing of other substances has been much more powerful because lithium is sort of an orphan drug. It's a drug that is not promoted by any company. Also, you know, lithium is sometimes not so easy to use. Some doctors feel insecure about using it. And there is also this medical component that some people have, actually some doctors have some sort of a allergy to it or phobia to it, which is the need to check the blood levels and to monitor the thyroid and the renal function. But at the end of the day, it is the most important treatment that we have for bipolar disorder. It's not for everyone, but it's very important. In this study, we checked the prescription patterns. We confirmed the declining use of lithium, which is unfortunate, and the increase of the use of antipsychotics, which may be partly justified, especially because antipsychotics have become the gold standard for bipolar depression, which was unexpected years ago. The first proof was the trial that we published in the American Journal of Psychiatry with Mauricio Toin on olanzapine and olanzapine in combination with fluoxetine, and then the quetiapine studies, the lurasidone studies, cariprazine, and others have shown the efficacy. So there is a justification for more use of antipsychotics. They also help to prevent relapse, but I don't think it is really justified so much use of antipsychotics as we detected in that study. And the use of valproate, always remember, you should not use valproate in women at childbearing age because of the risk of teratogenicity, which is really high. In fact, in this publication, again, with several international colleagues, we did a survey to see which was the gold standard for treating patients with bipolar disorder, and the best experts, almost all of them agreed, as you can see, around 75% of them agreed that the first option should be lithium. Another 20% said it should be a second option. And I mentioned before the Danish registry as one of the most important, and I also mentioned the Taiwanese registry because it's also high quality. So with Taiwanese colleagues and with André Carvalho, we analyzed a big number of patients, over 54,000 patients and more than 270,000 controls, to look into whether patients with a first episode of mania would have greater mortality than controls, and this was confirmed. So bipolar disorder, even from the first episode, is associated to greater mortality, not only because of suicide, but also because of other comorbidities. And in fact, only lithium was able to reduce all-cause mortality. So it's very important because it can reduce mortality by several means, of course, because of anti-suicidal effects, but also because of other effects. We have very recently published this paper that I think for any of you who's interested in being very up-to-date on the treatment of bipolar depression is a very nice summary of what is available and how it works. So this is, and you can see the figure is very comprehensive and complex. We have done what is called a network meta-analysis. Network meta-analysis means that you compare all drugs with each other, even in the absence of a head-to-head study. So what we are doing here is to take advantage of all the compounds that have ever been tested for bipolar depression and make assumptions either because of the head-to-head studies and do a meta-analysis of those, or by making the assumption that they can be compared indirectly through the comparisons versus placebo. And this is why the placebo red dot is the largest one, because the size of the dot correlates with the number of patients that have been exposed to that treatment. So through this network meta-analysis, which is a methodology that is the most helpful then to write treatment guidelines and to make some sort of hierarchy of the best treatments, we can say that this is the most comprehensive comparative analysis of efficacy and tolerability of treatments, of pharmacological treatments for bipolar depression. Basically, the results confirm that antipsychotics have greater efficacy but worse tolerability than other compounds. So, as I mentioned before, antipsychotics are being more and more used, but we need to make the right choice because not all antipsychotics have antidepressant properties, at least at the dose that they were tested. And we also need to keep in mind that antipsychotics carry more side effect burden, especially in some cases for weight gain and metabolic problems. And in other cases, it could be sedation or it would be extrapyramidal symptoms. And interestingly, in our analysis, antidepressants and lamotrigine also have a role, even though many acute studies do not show or do not prove that they actually work. But from this pooled evidence in this network meta-analysis, there is some evidence that they may work. And of course, it is important, especially for antidepressants, to combine them with the mood stabilizers or antipsychotics to prevent mania. New data on other compounds, for example, cariprazine has recently been approved for mania and depression in the US. It's mostly approved for schizophrenia in Europe. And this is a study that we did with Roger McIntyre showing some promising effects on functioning and on cognitive functioning in particular. And there is also lumateperone, that is a treatment that you may not be familiar with because it's not been marketed yet in Europe. I think what is interesting from this compound is the mechanism of action, which combines dopamine and serotonin antagonism, as many other antipsychotics, with glutamatergic action, which is a novelty and is something that you may have in mind as associated to esketamine and other compounds. And it's also interesting to see that they were bold enough to do a trial in bipolar 2 depression. So not only bipolar 1 or bipolar 1 and 2 mixed in the same study, but actually a standalone study on bipolar 2 depression, and this is positive. It's a once-a-day oral pill, 42 milligrams to be taken with food. It's approved in the US already, and it has very low weight gain liability, which is very important, but it's quite sedative, have little extrapyramidal symptoms, but it's quite sedative as much. More news. This is a paper that our group, myself as lead author, published recently in European Neuropsychopharmacology, doing an analysis, a pooled analysis of all the long-term studies with lamotrigine. What we wanted to do is to check whether lamotrigine would be effective and safe in a subpopulation that is very relevant because, as I mentioned before, drugs like valproate can be very dangerous in young women at childbearing age because the teratogenicity is really huge. It's not only based on malformations, also in low IQ and cognitive effects. So we need an alternative to valproate. Of course, lithium is an obvious one, but also lamotrigine is interesting. And we did this analysis from the raw data from the trial. So it's not just a meta-analysis, it's actually a mega-analysis on individual data set. And we proved that lamotrigine has positive effects preventing depression in that population. Getting to almost to the end of my update on bipolar disorder, I want to emphasize this important study. And it's a pity that we were not, in this case, part of it, because practically almost all the slides that I showed had some participation of our group. Not in this case. This was a trial that was led in Vancouver by Lakshmi Yatham and his group, and he did a multi-site trial that was very important because it provides, for the first time, evidence that actually when patients respond to antidepressants in the context of bipolar disorder, which means that they were mostly treated not as monotherapy, but combining antidepressant with lithium or with a mood stabilizer or antipsychotic, those who respond to antidepressant should not be discontinued in at least 1 year. So even though if you read the paper published in the New England Journal of Medicine, which is a very prominent journal, you may read that there was no reason to maintain the antidepressant. This analysis was based on a combination of relapse into any mood episode, so combining relapse into mania and depression. But when you separate the analysis for prevention of mania versus prevention of depression, the difference in relapse of manic episode was not significant, but it was significant, the difference between stopping antidepressant after 8 weeks or stopping antidepressant after 1 year, favoring a 1-year treatment. So this is an important new study that shows that antidepressants have a role, not only in the acute treatment, but also in the maintenance treatment. And how to use antidepressants in bipolar disorder is one of the most difficult things, not only in this field of psychiatry, but in psychiatry in general. It really needs a very skilled clinician. I also want to mention this paper, not only because I think some of the authors may be in this Congress, and they're very prominent authors from Italy, but also because it's one of the first evidence of esketamine in bipolar depression. It's an important study. It is an open study, so it's not a controlled clinical trial, but it's an important study with a very reasonable number of patients, 70 patients, comparing bipolars and unipolars, showing no difference. And that was obviously my guess, as everybody, that esketamine would work in bipolar depression. The open question was whether it would induce switches into mania, and apparently there were no switches. So this is important because the switch risk may be very low, and therefore it is safe to use esketamine in bipolar depression. But of course, we need randomized controlled trials to confirm these initial findings. And for the future, I think we need to think also on other treatments that are being developed for treatment-resistant depression. And one example is psilocybin. Psilocybin is that compound that can be obtained from magic mushrooms, but of course there are synthetic versions that are now being studied by several companies, including Compass. And this is the first study that has tested psilocybin in bipolar patients, particularly bipolar 2. It's again an open study. It's a small study, 15 patients only, but again, the results look quite positive, and also there was no evidence of switch into main. So I think this is good news for the field, and we are awaiting the controlled trials to confirm these findings. Just to mention non-pharmacological treatments, deep brain stimulation. These are 4 patients that we have treated in our place, and we have very good results on deep brain stimulation in bipolar patients with rapid cycling, really extremely severe cases of bipolar disorder in whom even ECT has failed. And of course, psychoeducation. And now what the modality we're using is this one. This is the manual that you can see on the right side, Psychotherapy for Bipolar Disorders, an integrative approach. And this is the trial that showed the efficacy of this intervention that combines psychoeducation, family intervention, physical health care, and also some mindfulness, along with cognitive and functional remediation. So this is a sort of integrative approach from all the developments that we've been making over the past 20 years and this is what we're using now. It's a shorter intervention than the usual one that we used to do 6 months. This is now 3 months only, and it's working very well. So my last slide, and just then the farewell, but this is a paper that is very important, again, with several authors, and this is led by Mario Mai, and it's a paper on personalized treatment, the ultimate goal, and this is for bipolar disorder. So I strongly recommend this paper to be up to date and to understand how to apply precision psychiatry and personalized psychiatry to bipolar disorder. Just to finish, to acknowledge and to appreciate my group work. This is the structure of our group. We are now quite a big group. We have over 40 people doing a lot of things, different things on neurobiology, on genetics, on neuroimaging, and of course on clinical trials on drugs, on psychological interventions, on neuromodulation. Everything that concerns bipolar disorder is our objective, trying to improve the lives of those patients. So thanks to my group, and many thanks also to all of you. I'm very happy and proud to do this introductory lecture to this important congress. Thank you.